Good morning, I am Assistant Professor Dr. Dalya Basil, and this is another lecture in medical microbiology. First, we will talk about the Bordetella, which contains several species of Bordetella. Bordetella pertussis, a highly communicable and important pathogen of humans, which may cause whooping cough or what we call pertussis. Bordetella parapertussis can cause a similar disease, while Bordetella bronchoseptica occasionally causes respiratory disease and bacteremia in humans, primarily in immunocompromised hosts. New species were discovered, such as Bordetella heinzii, which may cause bacteremia and respiratory illness, Bordetella holmesii, which may cause bacteremia among immunosuppressed patients. So there is a bacteremia only if there is an immunosuppression. And finally, Bordetella trematum, which was found in wounds and otitis media. Bordetella pertussis, Bordetella parapertussis, and Bordetella bronchoseptica are closely related. That means we can consider all these species as three subspecies within one species due to great similarity or DNA homology with 72 to 94%. The organisms are small gram-negative coccobacilli. When we use toluidine blue stain, we can see metachromatic granules at the two ends of bacteria, and also capsule may be present, or we can see capsule. Boarded jungo medium or potato blood glycerol agar that contains penicillin G with 0.5 microgram per meter can be used. The plates are incubated at 35 to 37 degrees centigrade for 3 to 7 days in a moist environment. Moist environment can be provided by using of sealed plastic bag. Bordetella pertussis is non-motile. There are many antigenic structures and virulence factors aid the bacteria to be an important pathogen for humans, such as Bordetella virulence genes, Bordetella virulence gene A and S, which are present on one locus on the Bordetella pertussis chromosome, acts as a central regulator of virulence genes. Bordetella virulence gene S responds or associates to environmental signals, while A is a transcriptional activator of the virulence genes. When stimulated or activated, will result in producing of a virulent factor or making the bacteria to be a virulent bacteria. Number two, the filamentous heme agglutinin mediates adhesion to ciliated epithelial cells of respiratory system. Pertussis toxin promotes lymphocytosis, sensitization to histamine, and enhance insulin secretion, which promotes the stimulation or stimulate the cough. 4. Adenylate cyclase toxin, dermonecrotic toxin, and hemolysin also are regulated by the Bordetella virulence genes system. The tracheal cytotoxin inhibits DNA synthesis in ciliated cells and is not regulated by Bordetella virulence genes. Number 5. Villi probably play an important role in adherence of the bacteria to the ciliated epithelial cells of upper respiratory tract. Also, the lipopolysaccharide in the cell wall of the bacteria may also be important in causing damage to the epithelial cells of the upper respiratory tract. All these factors that I mentioned are very important in the pathogenesis and pathological changes that may caused by the invasion or infection of Bordetella pertussis to the upper respiratory system cells. Bordetella pertussis is transmitted via respiratory route from patient to other individuals or from a carrier to other individuals, and the organism adheres and multiplies rapidly on the epithelial surface of the trachea and bronchi. Hemagglutinin, pili, and lipopolysaccharide of Bordetella pertussis aid the bacteria to invade the cells of respiratory tract and interferes with serial reaction of the epithelia of respiratory tract cells. The blood is not invaded. The bacteria liberate the toxin and substances that irritate surface cells, causing coughing and marked lymphocytosis. Later, there may be necrosis of part of the epithelium and polymorphonuclear infiltrations. That means polymorphonuclear cells, the first line of immune cells that may be attracted to the invasion sites, may be present, and peribronchial inflammation and interstitial pneumonia will occur also. And if there is a secondary bacterial invasion by staphylococci or Haemophilus influenzae, will give rise to bacterial pneumonia. Obstruction of the smaller bronchioles by mucus plugs results in atelectasis, and diminished oxygenation of the blood will result in convulsions, especially in infants with whooping cough. The clinical findings are depending on the disease stage. After an incubation period of about 2 weeks, the first stage will develop, or what we call the catarrhal stage. This stage is characterized by mild coughing and sneezing, and during this stage, large numbers of organisms are separated in droplets. In this stage, the patient is not very ill, and the clinical findings are not very severe, but the patient is highly infectious or highly contagious. While in the second stage of the disease, which are called its paroxysmal stage, the cough develops its explosive character and the characteristic whoop upon inhalation. This will lead to rapid exhaustion of the patients and may be associated with vomiting, cyanosis, and convulsions. Lymphocytosis may be developed, and there is an increase in lymphocytes. Bordetella pertussis is a common cause of prolonged 4 to 6 weeks cough in adults. Rarely, whooping cough is followed by the serious and potentially fatal complication of encephalitis. So there is a rare registration or observation of encephalitis accompanied with Bordetella pertussis. Nasal wash with saline is the preferred specimen. Nasopharyngeal swab or cough droplets expelled onto a cough plate held in front of the patient's mouth during a paroxysm are sometimes used, but are not as good as the saline nasal wash. A fluorescent antibody reagent can be used to examine nasopharyngeal swab specimen, and the nasal saline wash fluid is cultured on solid media agar. The antibiotic in the medium tend to inhibit other respiratory flora but permit growth of Bordetella pertussis. PCR is the most sensitive method to diagnose pertussis. Primers for both Bordetella pertussis and Bordetella parapertussis should be included because the similarity between these bacterial species. Regarding the treatment, administration of erythromycin during the catarrhal stage of disease promotes elimination of the organism and may have a prophylactic value. Oxygen inhalation and sedation may prevent anoxic damage to the brain. Every infant should receive 3 injections of pertussis vaccine during the first year of life, followed by a booster series for a total of 5 doses recommended prior to school entry to give prevention against pertussis. Pertussis vaccine is usually administered in combination with toxoids of diphtheria and tetanus. DPT vaccine. The usual schedule is administration of doses at 2, 4, 6, and 15 to 18 months of age, and a booster dose at age of 4 to 6 years. Now we will talk about Legionella. Several dozen species of Legionella exist, some with multiple serotypes. Legionella pneumophila is the major cause of disease in humans. Legionella mysidadi and a few other species sometimes cause pneumonia. The other Legionella are rarely isolated from patients or have been isolated only from the environment. Legionella are fastidious, aerobic gram-negative bacteria that are 0.5 to 1 micrometer in long. They often stain poorly by Gram's methods. Basic Foxin 0.1% should be used as the counter stain because safranin stains the bacteria very poorly. So we need to use basic Foxin instead of safranin. Legionella can be grown on complex media because it is a fastidious bacteria, media such as charcoal, yeast extract, agar with alpha ketoglutarate and iron at pH 6.9, temperature 35 degrees centigrade, and 90% humidity. Antibiotics can be added to make the medium selective for Legionella. The phagocyte oxidative metabolic burst is reduced because the presence of bacteria inside the macrophages, and not only the presence of bacteria but also the multiplication of the bacteria inside the macrophage, because the small vesicles accumulate around vacuoles containing the Legionella. The bacteria multiply within these vacuoles, and when there is an increasing in the numbers of bacterial cells, the macrophage will destroyed and the bacteria will invade other macrophages. The presence of iron, transferrin iron, is essential for the process of intracellular growth of the bacteria, but other factors important to the presence of growth, cell destruction, and tissue damage are not well understood. There is no prominent clinical findings in Legionella infection. Infection is asymptomatic in all age groups. Risk factors include smoking, chronic bronchitis and emphysema, steroids and other immunosuppressive treatment as in renal transplantation, cancer chemotherapy, and diabetes mellitus. Infection may result in nondescript febrile illness of short duration or in a severe rapidly progressive illness with high fever, chills, malaise, non-productive cough, hypoxia, diarrhea, and delirium. Chest X-ray reveal patchy, often multi-lobar consolidation. Legionella pneumophila may cause disease called Pontiac fever. This disease occurred in an outbreak in Michigan City. The syndrome or the clinical findings of this disease or of Pontiac disease characterized by fever and chills, myalgia, malaise, and headache that develop over 6 to 12 hours. So the headache persists for 6 to 12 hours continuously. Dizziness, photophobia, neck stiffness, and confusion also occur. Respiratory symptoms are much less prominent in Pontiac fever than in Legionella disease and include mild cough and sore throats. Bronchial washings, pleural fluid, lung biopsy specimens, or blood are used in laboratory diagnosis of Legionella infection. And because the Legionella are not demonstrable in gram stain, we should use silver stain to observe or diagnose the bacteria under light microscope. And because the Legionella is fastidious bacteria, we may use a complex media to culture the bacteria, such as buffered charcoal, yeast, agar. And regarding the serological test, the levels of antibodies of Legionella rise slowly during the illness. So the sensitivity of serological test is low, about 6 to 80%, 60 to 80%, but with a specificity of 95 to 99%. Macrolides, erythromycin, azithromycin, and clarithromycin, quinolones, ciprofloxacin, and levofloxacin, and tetracyclines, doxycycline are all of them are effective to treat or in the treatment of Legionella infection. Finally, we will talk about Haemophilus. Haemophilus species is a group of small gram-negative pleomorphic bacteria that require enriched media, usually containing blood or its derivatives for isolation. Haemophilus influenzae type B is an important human pathogen. Haemophilus ducreyi, a sexually transmitted pathogen, causes chancroid, an ulceration of lymphoid in the groin region. Other Haemophilus species are among the normal flora of mucous membrane and only occasionally cause disease. The bacteria is found on the mucous membrane of upper respiratory tract in humans. It causing respiratory tract infection in both children and adults, but it's causing meningitis only in children. The bacteria is short, 1.5 micrometer in diameter. It's cocobacilli, sometimes occurring in pairs or short chains. On chocolate agar, flat grayish-brown colonies with diameter of 1 to 2 millimeter are present after 24 hours of incubation of Haemophilus. Isovital X in media enhances the growth of Haemophilus influenzae. Haemophilus influenzae doesn't grow on sheep blood agar except around colonies of Staphylococci. This is called satellite phenomenon. It is a characteristic feature in the culturing of Haemophilus influenzae. Haemophilus hemolyticus and Haemophilus parahemolyticus are hemolytic variants of Haemophilus influenzae and Haemophilus parainfluenzae, respectively. When we need to identify the organism of Haemophilus group, it depends in part upon demonstration of the need of certain growth factors called X and V factors. Factor V can be replaced by nicotinamide adenine nucleotide or other Colonies of Staphylococci on sheep blood agar cause the release of nicotinamide adenine nucleotide, yielding the satellite growth phenomenon. So this is the characteristic feature for the growth of Haemophilus influenzae on sheep blood agar. Carbohydrates are fermented poorly and irregularly, so we can not we can't depend on the fermentation of carbohydrates in the identification of Haemophilus. Regarding the antigenic structure, encapsulated Haemophilus influenzae contains capsular polysaccharide. It is a large capsular polysaccharide with molecular weight above 150 thousandths of one of six types A to F. The capsular antigen of type B is a polyribose ribitol phosphate (PRP). Encapsulated Haemophilus can be typed by slide agglutination or agglutination of latex particle coated with type-specific antibodies. So, these serotypes of Haemophilus influenzae aid in identification or serological identification of Haemophilus influenzae. A capsule swelling test with a specific antiserum is analogous to the Quilling test for pneumococci. Typing can also be done by immunofluorescence. Most Haemophilus influenzae organisms in the normal flora of the upper respiratory tract are not encapsulated. The somatic antigens of Haemophilus influenzae consist of outer membrane proteins, lipo-oligosaccharides, endotoxins share many structures with those of Neisseria. After the entrance of the bacteria via respiratory tract, there may be local extension with involvement of the sinuses or middle ear. Haemophilus influenzae type B and pneumococci are the most etiological or causative agents of bacterial otitis media and acute sinusitis. The organism may reach to bloodstream and carry to the meninges, or less frequently may establish themselves in the joints to produce septic arthritis. So, after the distribution via the blood, the bacteria may cause meningitis, or if they reach to joints, produce septic arthritis. Prior to the use of the conjugate vaccine, Haemophilus influenzae was the most common cause of bacterial meningitis in children, especially at the age of 5 months to 5 years in the United States. The clinical symptoms of Haemophilus influenzae when causing meningitis resemble to any bacterial meningitis, and the demonstration depends on the bacteriological examination of the organism. Occasionally, a fulminating obstructive laryngotracheitis with swollen cherry-red epiglottis develops in infants and requires promote tracheostomy or intubation as a life-saving procedure. Pneumonitis and epiglottitis due to Haemophilus influenzae may follow upper respiratory tract infections in small children and old or debilitated people. Adults may have bronchitis or pneumonia due to Haemophilus influenzae. So there is many complications after the infection by Haemophilus influenzae may occur in patients. The specimens of laboratory diagnosis of Haemophilus influenzae are consist of nasopharyngeal swab, pus, blood, and spinal fluid if there is a meningitis. All these specimens are used to or for preparation of smear to observe the bacteria or examine the bacteria under light microscope and for culturing of the bacteria. There are several commercial kits available for immunological detection of Haemophilus influenzae. These kits are designed or prepared by for the detection of specific polysaccharide from Haemophilus influenzae type B. These antigen detection generally are not more sensitive than a gram stain, so they are not widely used. The golden standard test in laboratory is gram staining for the bacteria or of the bacteria. Specimens are grown on isobutyl X enriched chocolate agar, and the incubation will continue until the appearance of typical colonies. We can differentiate between Haemophilus and other related gram-negative bacilli by its requirements for X and V factors, and also by its lack of hemolysis on blood agar. Tests for X and V factor requirements can be done in several ways. One of this way by using of a paper strip or disc containing V factor placed on the surface of agar. This agar will be autoclaved before adding of blood because V factor is heat labile. Alternatively, a strip containing X factor can be placed in parallel with one containing V. So there is two discs, one containing V factor and other containing X factor. Growth of Haemophilus in area between the strips or disc or indicates the requirement for both factors. The mortality rate of untreated cases of meningitis caused by Haemophilus influenzae is high. It's about 90%. Many strains of Haemophilus influenzae type B are susceptible to ampicillin, but up to 25% produce lactamase under control of a transmissible plasmid and are resistant. So 25% of Haemophilus influenzae may have antibiotic resistance against ampicillin. Essentially, all strains are susceptible to the third generation cephalosporins. This is the end of our lecture. Thank you for your listening. If you have any question, please contact me or send a message in the Google Classroom of Medical Microbiology of second stage in College of Pharmacy, Mustansabia University. Thank you again.